Cardiff, United Kingdom. Before we start, I'll go over some housekeeping rules. Kindly make sure that you rename yourself with the name as it should appear on your participation certificate. Towards the end of the lecture, we will share a link on the chat box. Please fill it out so that we can provide you with your certificate. Please note that attending the lecture for a minimum of 45 minutes and completing this form are necessary to obtain the certificate. A Google form, the Google form will consist of 3 multiple choice questions, and you have to select only one true answer in the check boxes. The correct answers for the course test and certificate will be sent to you via email. Kindly keep your microphones muted throughout the session. If you have any questions, don't hesitate to type them in the chat box. We will address them later. Dr. Udakumbura, over to you, sir.
Thank you very much. Thank you for College of Family Physicians for inviting me to do this talk. So without wasting any more time, we'll straight away start the lecture. So this is about the primary care approach for acute and like basically loss of vision. So loss of vision, there are several types of loss of vision. So it can be, we can categorize it into 3 broad categories. So it can be complete loss of vision, partial loss of vision, central loss of vision, peripheral loss of vision, and some can say blurred vision and transient visual obscuration. So this is a very little bit busy slide, but a lot of MCQs and some MCQs here. So hello, can you hear me? Can you all hear me?
Yes,
we can.
Yeah. Okay, brilliant. So this is so I kindly ask all the participants to mute themselves. Otherwise, it can be a nuisance to the others. Thank you. So basically, this is about the visual loss in terms of the visual field. So complete loss of vision is like basically the whole visual field is affected. So partial loss of vision means part of the visual field is affected. Central loss, as it says, it's the central bit, and the peripheral loss, it's the peripheral visual field. And the blurred vision is not entirely a visual loss, but the vision is not 100% okay. So it's like a slight blur. And transient visual obscuration is very important. It's very specific for raised papilledema due to raised intracranial pressure. So disc edema due to raised intracranial pressure is papilledema. And when you have papilledema, you can get complete loss of vision for few seconds, and then it recovers back to normal, especially when you lean forward, stand from lying down position, you can get these transient visual obscurations like loss of vision for few seconds. This is not pathognomonic for papilledema, but it's very specific for papilledema, disc edema due to raised intracranial pressure. Okay. And the other category of, we can categorize loss of vision into acute onset and gradual onset. Okay. So acute onset is usually loss of vision happens due minutes to hours. So within minutes to hours, there is loss of vision. Gradual onset is like usually months to years. But there's a bit of a gray area like days to weeks. Sometimes it can be put into acute. Sometimes it can put into gradual. So usually days we say more or less acute, but weeks usually it's gradual usually. So acute loss of vision, most common causes are fresh retinal detachment, acute angle closure, acute endophthalmitis, GCA is giant cell arteritis. It is a condition, it's an arteritic ischemic optic neuropathy. Very common in Caucasians, not common in South Asia. Very common in this part of the world, in Western world. And optic neuritis, again, acute. And corneal ulcer, central retinal artery occlusion, central retinal vein occlusion, diabetic retinopathy can be acute but usually remember diabetic retinopathy is gradual. Diabetic retinopathy can give rise to acute loss of vision if it develops a vitreous hemorrhage inside the eye. Okay, so it usually gradual but can cause acute loss of vision. Likewise, the gradual loss of vision, most commonest is the cataract, but very rarely cataract can happen acutely when it follows a trauma. Traumatic cataract can give rise to acute loss of vision, right? So usually gradual, but rarely acute. So what happens is we usually remember the rare stuff in the MCQs and then we get into trouble. So remember the common scenario. So cataract is gradual, but rarely acute. Glaucoma, gradual loss of vision, but exception is the acute angle closure glaucoma, where the loss of vision is acute. RP is retinitis pigmentosa, central serous retinopathy, which is a condition where fluid accumulates underneath the fovea. Okay. Refractive error, very common cause of gradual loss of vision. And compressive optic neuropathy following optic nerve glioma, meningioma, it's usually gradual. AMD is age-related macular degeneration. It's usually gradual, but rarely it can cause acute loss of vision following a hemorrhage near the fovea as a complication of macular degeneration. Drug toxicity, again, usually gradual, but say, for example, methanol poisoning, it can be acute. I don't know, Kasipubila, so it can be acute. So, next slide. The other category is whether it's painful or painless. Corneal ulcer, acute angle closure glaucoma, endophthalmitis, giant cell arteritis, corneal abrasion, painful. Painless, vein occlusion, arterial occlusion, retinal detachment, cataract, drug toxicity, macular degeneration, retinitis pigmentosa, glaucoma, except for acute angle closure glaucoma, and diabetic retinopathy, painless. Okay, so we'll start from very common stuff first. So this is a cataract. This white thing at the center is the cataract. So this is an advanced state of a cataract, and this is an early state of a cataract. So usually a clear lens, but there's in the middle. Can you see my cursor? You guys can see my cursor?
Yes,
Yes,
Okay.
we can see.
Yeah,
yes,
good.
sir.
So there is some central white haze. That's an early cataract. So usually early cataract, we can manage with spectacles. So we can improve the vision with spectacles for a certain degrees, but after that you can't. Okay. This is a special type of cataract where there's a central opacity, but the peripheral rim is clear. So I put this image specifically to show you the normal color of the lens. So this is the normal color of the lens. It's usually transparent, and this is the normal color, right? So there's this bit, no cataract, but there is a central haze. This is called anterior subcapsular cataract. You don't have to know it. And this is a moderate cataract where there is yellow to greenish tinge at the cataract, and there is some pigment deposition at the periphery. So this is a moderate cataract. So usually cataract causes gradual loss of vision. It's painless. It usually complete. Whole visual field is affected, but in special type of cases like which I showed you earlier, so central bit can be affected, or you can get like peripheral partial block of vision as well in certain types of cataract, but generally it's complete. visual loss is gradual, but people can present saying, oh, I lost vision overnight. What happens usually is they close one eye and then suddenly realize, for some reason they close one eye and then suddenly realize their vision in the other eye is not very good. That's what happened. So you have to be very cautious when they say sun loss of vision. Just ask the history. How did they found out that they lost the vision? So very important to ask in detail history. How did they found out that their vision is lost? Factors affecting cataract formation: age. After 40, 50 years, everyone has a certain degree of cataract. It's very common. Trauma is a well-known factor. Iatrogenic, especially any intraocular surgery. Drugs like systemic steroids can cause cataracts. And systemic medical conditions like diabetic retinopathy increase the progression of cataract. And hypocalcemia increases the chances of having a cataract. Any condition that give rise to hypocalcemia. And any intraocular inflammation increases the chances of having a cataract. So I'm just going to show you this video. I think it's just for your to give an idea what is a cataract operation. It's about 2 minutes. Right. Can you see? I think you all can see the video, aren't you? Right. So the surgeon injected some solution to dilate the pupil first, and now just putting some jelly viscoelastics to maintain the anterior chamber, and then putting the incision now. So it's 2.2 millimeter incision, very small incision. And then now, so the lens is in a lens bag. There's anterior capsule and a posterior capsule. So he's making a hole at the front surface of the lens. So he's making a hole at the anterior capsule so that we have the access to the lens matter. So lens matter is covered by a lens bag. The lens bag has anterior surface and a posterior surface. So he's making a hole at the anterior capsule. Anterior capsule, lens matter, and posterior capsule. And now he's separating the lens matter from the bag by sending a fluid wave. And now, so that's the pink probe with a big tip is the phaco probe, and the other one is a supporting instrument. Now he's going to break the lens into 2 pieces. He broke it, and now he's breaking it to 4 pieces and taking it out. And so this phaco probe send ultrasound impulses. Ultrasound impulses break the lens into small pieces, and it suck it out with the vacuum. Right. Now he's breaking that half into 2 quadrants, and each quadrant is sucked out with the ultrasound energy. Right. This is the normal speed of a cataract, so it's very quick. And there are some leftovers in the bag, which is called the cortical matter, and he's going to clean it now. Yeah. So he's cleaning the bag with the residual lens matter. Cleaning all the residual lens matter. So it takes about 10 minutes to do the cataract, but mind you, there's a long learning curve. Right. Now he's going to fill the bag with some jelly viscoelastics to form the volume, and then he will inject the lens. So the lens is folded, and in the eye it's get unfolded. So the lens is getting unfolded now. That's the artificial lens, and that's it. And finally, he will remove all the viscoelastic. So it's basically a very simple operation, but has a very long learning curve. So right. So the next condition is retinal detachment. Retinal detachment is the separation of neurosensory retina from the underlying retinal pigment epithelium and choroid. So the retina, neurosensory retina, is loosely attached to the underlying choroid and the sclera. There is no anatomical strong attachments. When some conditions, some like trauma and intraocular operations can give rise to a retinal tear, and from that tear, fluid goes in between the retina and the choroid and separate the neurosensory retina, forming a retinal detachment. So acute macular attached retinal detachment is an ophthalmological emergency. So there are only few ophthalmological emergencies in luckily. So one of them is acute macular attached retinal detachment. Macular attached is usually, we don't use macular attached term. In ophthalmology, we used macula on. But it's quite confusing. That's why I use the macula attached. Macula attached or macula on retinal detachment is an ophthalmological emergency. We have to do surgery within 24 hours. But macula detached retinal detachments, that is called macula off retinal detachments, you can wait 2 to 4 days. So if someone comes to you and you found out that he has a retinal detachment, and if his vision is good, central vision is good, it's very highly likely that his macula is attached. So you have to send the patient straight away on the same day to a ophthalmology department, right? But if the vision is very poor and the retina is detached, that means the macula is not attached, macula off. Those patients can wait 2 to 4 days. So if they comes to you on a Friday afternoon, you can send them Monday morning to the ophthalmology department, right? Okay, so this picture shows, so there's a retinal break here. From that break, the water in the vitreous goes inside and separate the retina from the underlying layers. That's the retinal detachment. Okay, so this is a retinal detachment. And so this is a actual picture. So this whitish, there's this line. That's the line of attached and detached retina. This area is attached, this area is detached, and this is the retinal tear. This is the retinal tear. Okay, so from that tear, fluid goes in and separate the retina. And this is again, this is the optic disc. These are the normal blood vessels. And this pink retina is the nasal retina is attached, but the temporal retina is whitish compared to the healthy attached retina, and it's corrugated, and it's like a orange appearance. So this area is detached, and the fovea is attached still. It is still attached. So this is a macula on or macula attached retinal detachment. This is emergency. So they present with flashes, floaters. Flashes means they say, and floaters, flashes means they said, they will say, light there is some lightning sensation inside the eye. And the other thing they will say is there's a curtain-like thing blocking the vision, which progress from periphery towards the center of your vision. රෙද්දක් දැම්ම වගේ පේන උඩින් ඉඳන් පල්ලෙහාට හරි පල්ලෙහා ඉඳන් උඩට හරි එහෙම තමයි කියන්නේ. And it's painless and usually minutes to days. And risk factors are high myopia, because high myopes, their retina is very thin and they have a high chance of a retinal tear. Trauma and any vitreoretinal degenerative condition like Stickler syndrome or any intraocular surgery. These are the risk factors, common risk factors. So what we do is so they need surgery. There's no other treatment. So we put 3 ports into the eye and an infusion port to maintain the intraocular pressure, and then 2 other ports, light probe and a cutting instrument, and then we do the surgery it's like endoscopic surgery. So in primary care setting, if someone comes to you saying flashes, floaters, just don't ignore them. Don't think like that. Just take it seriously. If the patient says flashes and floaters and vision is okay, you have to send them immediately to ophthalmology department if you don't have access to see the fundus. So very important, flashes, floaters, curtain-like thing blocking the vision, just send them immediately to ophthalmology department to have a good look. What happens usually is the GPs, can't blame them, they don't have a proper training, so they give some lubricant, refresh tears or something, and then they comes with a chronic retinal detachment. So always send them to the ophthalmology department. The next case is central retinal artery occlusion. So it's a sudden loss of vision within seconds to minutes, painless, and it's usually a complete loss of vision. There are exceptions, but for your exam purposes, remember it's as a complete loss of vision. Usually it's a complete loss. Complete loss means from 6/6 vision to 6/60 hand movements. That kind of a rapid reduction of vision. And this is a typical appearance of the retina of central retinal artery occlusion. So this spot at the center, reddish spot, is called cherry red spot. So it's very famous cherry red spot, and the surrounding retina is pale, edematous, and thickened. So it blocks the transmission of red color from the choroid. But the fovea is very thin, it doesn't get edematous, so it doesn't block the transmission of red color from the choroid. That's why you see the cherry red spot. It's not due to accumulation of blood or anything. It's basically a relative transmission of color of the choroid. Okay. This is a branch retinal artery occlusion, where the superior branch of the retinal artery is occluded, but the inferior part is nice and healthy, very well perfused. The superior part is blocked. You see the white edematous pale retina. Yeah, so they get like a partial loss of vision. So when there's a superior retinal artery occlusion, you get inferior visual field defect. All right. So risk factors: diabetes, hypertension, hyperlipidemia, any cardiac valvular disease which can give rise to emboli, shooting emboli. So emboli shoots to the carotids and then goes to the ophthalmic artery and then block the central retinal artery. Any carotid atherosclerosis disease can give rise to shooting emboli again, and same thing can happen. So these things you have to investigate for these things if you encounter a patient with central retinal artery occlusion, because next thing can be a full-blown stroke. So CRAO is considered as a mini stroke. It's a mini stroke. So if you don't investigate and treat the cause, they can end up with a full-blown stroke. So if they present within few hours, hypothetically in Sri Lankan situation, if within few hours, immediately refer to the ophthalmology department, because we can do something, we can have a look, and if we see emboli, we can do some some procedures to dislodge the emboli, but not supported by any trials yet, but there are things that we can do. If they present after a couple of days, usually the fundus can be normal because the retina goes back to the normal state. They get reperfused, but the damage done is permanent, so the vision will be poor, but the retina will appear normal after 4 or 5 days, and we don't have there's nothing to do. Basically, eye is gone. The important thing to remember is if you get a retinal artery occlusion, there's a 10% chance it can happen in the other eye. So you have to investigate and find the cause and treat it. Otherwise, it will have, there's a high risk that it can happen to the other eye. Right? So they do the basic blood investigation, carotid duplex, if there's a murmur, cardiology referral. So in primary care setting, just systemically optimize the patient. And if they present acutely, send them immediately to the ophthalmology department. If they present late, still you have to refer, but not urgent, like you can send them next day. Okay. CRVO again cause sudden loss of vision, painless. It is broadly divided into ischemic and non-ischemic central retinal vein occlusions. Ischemic type is the more damaging one. It causes rapid dramatic reduction of vision from 6 to hand movements, very poor prognosis. Non-ischemic one, the visual loss is not that bad. It can be from 6 to 636, 624, like partial loss of vision. Partial in the sense it's not like a visual partial part of the visual fields, but the reduction of the vision is not as bad as in as in a ischemic type of a central retinal vein occlusion. Branch retinal vein occlusion is one of the branches of the central retinal vein is blocked, so you get only one part of the retina is blocked from blood collection, and they get partial loss of visual field. Like, say, for example, if the superior half of the retina is blocked, you get an inferior visual field defect. So this is a classic picture of a central retinal vein occlusion. So there is hemorrhages in all 4 quadrants, engorged veins, and the arteries looks normal. So what the main problem with the medical people is to understand, identify this from the diabetic retinopathy. So in diabetic retinopathy, there are exudates, like whitish, yellow-white things at the macula. But here you can't see any yellow-white spots. So if you see yellow-white spots in the macula, that is more likely diabetic retinopathy. But history also gives you more information, because diabetic retinopathy without a significant vitreous hemorrhage, they don't give rise, they don't say that it's a sudden loss of vision. It's usually a gradual. But if you see this kind of a picture with sudden loss of vision, it's like a central retinal vein occlusion. Okay. And there is no exudates in the macula. All right. This is more extensive central retinal vein occlusion, lot of hemorrhages, and disc is also edematous. This is ischemic type of a central retinal vein occlusion. And this is a branch retinal vein occlusion where one of the branches of the retinal vein is blocked here. So they get this is superior temporal branch retinal vein occlusion, and they get inferior visual field defect. Okay. So this, so one of the complications of vein occlusion is macular edema. So this small mountain at the center is, and some cyst, fluid-filled cyst. This is a macular edema. And in retinal artery occlusions, you don't get this kind of macular edema. What happens in there is the inner retina diffusely get edematous, right? Here, the central bit get edematous, and there's fluid-filled vacuoles as well, but you don't see them in central retinal artery occlusion. Okay, so risk factors again: diabetes, hypertension, hyperlipidemia, any condition that increases the hypercoagulability, like protein C and S deficiency, factor V laden disease, so lupus anticoagulant, antiphospholipid antibody syndrome, and myeloproliferative disorders. Raise intraocular pressure. So glaucoma is a risk factor for central retinal vein occlusion. And any inflammatory disease like sarcoidosis, Behçet, can give rise to central retinal vein occlusion. So management is systemic optimization, and we need to find the cause and treat the cause. So if it is due to diabetes, poor control diabetes, then you have to treat that. Otherwise, there's a risk of same thing happening in the other eye. Okay. So, and if the patient has macular edema, the ophthalmology department will treat them with intravitreal injections, what is called anti-VEGF, antivascular endothelial growth factor injections. And central retinal vein occlusion is well known to cause retinal neovascularization, retinal new vessels. Because of the ischemia in the retina start producing new blood vessels. Then these new blood vessels are very leaky, and they can bleed at any time and worsening the vision. So to prevent that, we burn the peripheral retina. We sacrifice the peripheral retina to safeguard the central vision. And another complication is neovascular glaucoma, where they get high eye pressure, which need to treat with anti-glaucoma medication. So this picture is again shows the macular edema, swelling at the fovea with fluid-filled vacuoles in the left. And then after injections, you get the resolution of macular edema. This dip at the center is normal. That's the foveal normal architecture, right? So this is the normal architecture at the center in the fovea. This is normal. Yeah, again, superior branch retinal vein occlusion giving rise to inferior visual field defect. And when you get new vessels, you burn the peripheral retina. These white spots are the laser mark, fresh laser marks. And then spare the central retina, macula, so that we reduce the ischemic drive and reduce the chances of new blood vessel formation. Right. So in primary care setting, the patient comes with sudden loss of vision, and then there's a risk factors: diabetes, blood pressure, poorly controlled usually, and then you check the blood pressure, do a random blood sugar, and have a look. If you can have a look at the back of the eye with your funduscope, and if you see a lot of hemorrhages all over the fundus, it's highly likely that it's a central retinal vein occlusion. Send the patient next day to the ophthalmology department. So if you follow up that patient, just make sure that he's systemically optimized. If he's a young patient, we need to investigate further for rare diseases like hypercoagulable diseases. Okay. And diabetic retinopathy is usually gradual loss of vision, but can be acute if the patient develops a vitreous hemorrhage secondary to retinal neovascularization. It's directly related to the poor systemic control, and it increases the chances of cataract progression. And they also get macular edema. Treatment is intravitreal anti-VEGF injections. New vessels, they develop new vessels, and treatment is laser. If they develop a vitreous hemorrhage, sometimes they can develop tractional retinal detachment at the back of the eyes due to proliferating new vessels, causing traction to the retina. So it's a variety of retinal detachment, tractional retinal detachment, very common with our eyes, Asian eyes. So we operate 1 or 2 cases every day in a list in Sri Lanka with these tractional retinal detachments. These patients need surgery, vitrectomy. So no other way. And this is the classification for diabetic, famous ETDRS classification of diabetic retinopathy. So it broadly categorized into non-proliferating diabetic retinopathy and proliferating diabetic retinopathy. Non-proliferating diabetic retinopathy, we usually manage conservatively. So the endocrinologist has to optimize them systemically. Whatever we do to the eye will not be in effect if the control is poor. And proliferating diabetic retinopathy, we do injections if there's macular edema. If there's new vessels, we burn the retina, peripheral retina. Doing laser treatment, it reduces the chances of a new blood vessel formation by 50%. And if there's a bleeding, then we do vitrectomy, take the blood out surgically. Yeah, so these dot and dot hemorrhages are very common with diabetic retinopathy, and these yellowish spots are the exudates. And this is an angiogram of the retina. I don't know whether you guys can see these small white spots are microaneurysms, right? They are microaneurysms. And there's more dot and blot hemorrhages and exudates and cotton wool spots. Cotton wool spots can also see in diabetic retinopathy, not too much, not pathognomonic, but it can have, usually we see them. And so this is again, you can't see any new vessels, but this is like a severe non-proliferating diabetic retinopathy where you get hemorrhages in all four quadrants and a lot of exudates. So sometimes you can get confused this with central retinal vein occlusion, but you can't see any usually this amount of exudates in central retinal vein occlusion. Again, lot of exudates, yellowish spots, and dot and blot hemorrhages. And these are famous vascular changes in diabetic retinopathy, venous looping, and venous segmentation. And these are the new vessels. These are new vessels at the disc, NVD, and these are new vessels elsewhere, which is called NVE, like a frond. It grows like a frond. Normal blood vessels are very regular. See, they are very regular, normal blood vessels. But abnormal blood vessels, they grow haphazardly, like a frond. And this is an angiographic picture of the retina where it shows leaking from the new vessels. Yeah, this picture B shows fresh laser treatment for new vessels. These white spots are the laser marks, and with time they get pigmented and get scarred. Okay. And this is a hemorrhage from new vessels at the disc. It's like a waterfall of hemorrhage here, and there's a big blob of hemorrhage here. This is called a subhyaloid hemorrhage. So it's covering the macula, and the patient comes with acute loss of vision. Right. And age-related macular degeneration, again, it's usually gradual, but can be acute at the onset of wet AMD. So age-related macular degeneration can be categorized into wet type and dry type. Dry type is the better type, actually. They progress very slowly, but wet type, their visual prognosis is very poor. However, unfortunately, we don't have any treatment for dry AMD. But for wet AMD, we treat them with intravitreal anti-VEGF, antivascular endothelial growth factors. Usually, it's painless. It's definitely painless. Not usually, it's a painless thing. And above 60, patients comes with distortion at the center. Patients will tell you that there's difficulty in reading. Lines are distorted. And so the problem is basically at the center. Their peripheral vision is fine. And For dry AMD, there's not much proven treatment. Only thing is the multivitamins. This AREDS formula multivitamins. AREDS is the one of the landmark studies, age-related eye disease study. So that study has shown that taking some multivitamin capsules, there are specific formulas, not all the types. There are macula-friendly formula. If you take them, it will reduces the progression by 18%, right? And we encourage the patient to eat green leafy vegetables, oily fish. Has a benefit, they say, but not proven with big multi-center studies. And wet AMD, there's no other way. You have to treat with intravitreal anti-VEGF agents. Very poor prognosis. Yeah, so this is a picture of a macular degeneration. These white spots, they are drusen. And that now you will ask how you differentiate them from exudates. So exudates usually associated with retinal hemorrhages. You can't see a single hemorrhage here, aren't you? There's no single hemorrhages in the fundus, only the whitish spots, and it's in the center around the fovea. And then you can do what is called OCT to differentiate further. This is again drusen in the macula, no hemorrhages. It's subretinal, so you can see the blood vessels going above the lesions. In exudates, usually it's intraretinal, so it they might obscure the blood vessels, but this drusen is under the retina, so the blood vessels you can clearly see going above the lesions. So that is one way to differentiate. So this is the OCT scan, and these humps are the drusen, right? So it's under the retina, under the retinal pigment epithelium. And this is a wet AMD case where there's a bleeding at the center. From what happens is from the choroid, new blood vessels develop into the retina and they bleed, and then give rise to these hemorrhages. So this is a dry AMD case where there's atrophy at the center. And this is a wet AMD case where there's bleeding and fluid underneath the retina. You need to treat with anti-VEGF injections. So in primary care setting, for where AMD cases, they usually comes to you with distortion at the center. Peripheral vision is fine. They will complain of difficulty in reading, difficulty in watching telly. So just have a look. You might see some yellowish white spots, yellowish spots at the macula. No hemorrhages. Sent to the ophthalmology department. And then encourage them to have a very good healthy lifestyle, like eating vegetables, green leafy vegetables, and if they can afford, give them the AREDS formula. Optic neuritis, again, it's a sudden onset blurred vision. They don't tell you that vision is like very poor. It's not, it's like from 6 to it can be 612, 618, not hand movements or counting fingers usually. And they say, they will definitely say color desaturation. Especially, they will say the traffic lights, the red color is like pink, if they are very observant. And eye movements are painful. Eye movements are painful. Painful eye movements, color desaturation, blurred vision. In a female, in a childbearing age, female, that is optic neuritis unless proven otherwise. Onset hours to days. And even without treatment, simple optic neuritis starts settling after 2 weeks. And they get, they will say the vision is improving now gradually after 2 weeks. But you have to investigate for multiple sclerosis. Not very common in South Asia, but very common in Caucasian. So if you get an attack of optic neuritis in a female childbearing age, first attack maybe one of those things, but second attack, you definitely need to investigate for MS. So this slide, so optic neuritis is usually retrobulbar in inflammation of the optic nerve. So the disc is fine, right? But it can be inflammation of the optic disc as well, which is called papillitis. In that case, you see the disc edema. Sometimes it can involve the macula as well. In that case, it's called neuroretinitis. So these three has three separate. There are different differential diagnoses for these three. So retrobulbar optic neuritis is usually the classic form of optic neuritis, and you don't see any changes. So the clinician doesn't see anything, and the patient also doesn't see anything. And papillitis, you see the disc edema and patient complains of blurred vision as well. So this is the most common type of optic neuritis seen in children. They get disc edema, but in adult, they don't get disc edema. It's usually retrobulbar. And neuroretinitis is usually due to viral infections, cat scratch disease, and there are certain other diseases where you get neuroretinitis. But it's neuroretinitis very rarely as a sign of a demyelinating condition. Okay. Now, so this picture shows temporal disc fallow. So after optic neuritis, when it settles, after a couple of weeks, couple of months, you get temporal disc pallor. So this is very common after optic neuritis. So this bit is pink and healthy, the nasal bit, but the temporal bit is pale and yellow. Okay. And this shows the grading of optic nerve swelling. This is normal. There's slight disc edema here. Mild, moderate. This is severe. And this is settling phase. Okay. So after settling, after many months, you get complete pale disc like this. This is a complete pale disc. So you can observe this even with the direct ophthalmoscope. And this is a condition you get bitemporal pallor. So this is pale temporally, and again this is pale, but the nasal disc is pinkish. See, it's pinkish, but the temporal bit is yellow and pale. So very common bitemporal disc pallor in pituitary tumors. And this is again a pale disc seen in retinitis pigmentosa. So all these pigmented retinopathies give rise, later stages give rise to pale discs. And these pigmentary spicules are like a classic feature of any pigmented retinopathy. This is a retinitis pigmentosa case. So they start from the periphery and gradually encroach into the center. The blood vessels get atrophied and the disc get atrophied and get pale. Right. So primary care setting is female, childbearing age, blurred vision, color desaturation, painful eye movements, straight away to the ophthalmology department and neurology referral. Because we need to investigate, and there are new drugs that can help, and some physicians give systemic steroids, IV methylprednisolone, to speed up the process of recovery. So better always send them as soon as possible to the ophthalmology department. Endophthalmitis is extremely painful, extremely painful, excruciatingly painful. It's an angry looking eye, very poor vision. Acute endophthalmitis is onset is hours to days, But there's another form called chronic endophthalmitis, which is like many months, progress through many months. But usually the commonest form is the acute endophthalmitis. Usually we divide the endophthalmitis into endogenous and exogenous. So the exogenous one is usually the most common, where it follows a surgery, intraocular surgery, or trauma. Endogenous one is from their patient's own body, like indwelling catheters or cardiac endocarditis, infective emboli shooting into the eye. So they are very rare. Patients are usually ill and they don't come to you. They are in ICUs. So it's very unlikely you to see an endogenous case. But exogenous ones, usually common after cataract surgery, any intraocular surgery. Treatment is intravitreal and systemic antibiotics, failing vitrectomy, plasmina vitrectomy to take out the infective material. Very poor prognosis. Sometimes they end up with removal of eye, evisceration. So, yeah, so this picture shows very angry looking red eye. Cornea is clear. In contrast to a corneal ulcer, you get an angry looking eye, but the cornea is not very clear. And there's a bit here, that's the hypopion, inflammatory debris at the anterior chamber, bottom of the anterior chamber. That's a hypopion. Again, this one, there's hypopion, very angry looking eye. And you might, this is collection of pus inside the eye. The cornea is okay, right? So endophthalmitis. So if someone post-operative patient comes to you with red eye, angry looking eye, painful, don't treat them with any topical antibiotics like Cipro, any chloramphenicol. Send them directly to the ophthalmology department, okay? Corneal ulcers, onset hours to days, painful. They are very photophobic and their vision is usually poor. History of a foreign body going into the eye, very common, especially in harvesting season. Farmers comes with paddy seeds going into the eye. So ask for a history of a foreign body going into the eye. So what we do is scrape the cornea, send the scraping to the lab, do the gram stain, culture, and start intensive topical antibiotics and antifungals. So my advice to the GPs and all the people in the community not to start any topical steroids because it make things worse. So angry looking eye, hazy cornea, foreign body, history of foreign body going into the eye, poor vision. You can start topical antibiotics and send to the ophthalmology department, but never ever start anything containing steroids. You can make things worse. Yeah, so this is a corneal ulcer. So there's again hypopion here. And superficially, you can see the ulcer. So to differentiate this from endophthalmitis, we can stain it with fluorescein strips and use if there's a corneal ulcer, the ulcer takes up the fluorescein. So the greenish color is due to the fluorescein. So if the cornea is clear, if the cornea is not affected, the fluorescein will not take up. Right. So again, this is a central ulcer with a hypopion, very thin center, angry looking eye. Again, there's another corneal ulcer. So when the corneal ulcer doesn't respond to treatment, we have to do a corneal transplant. So this is a eye who had a corneal transplant for this corneal ulcer, multiple corneal sutures, and the central button. Right. So epithelial defects, very common. What happens is the people, the bike riders, and then children can get the things into the eye and they scratch the eye and then the superficial corneal epithelium peeled off. And the cornea is the most sensitive place in the body. And if you get a corneal epithelial defect, underlying corneal nerves get exposed and then it gives rise to severe pain and photophobia. So there is usually a history of trauma, but the eye is less angry looking, not very red, not very much bloodshot. But pain is out of proportion to the sign. Sometimes you might think, oh, this guy is malingering. So pain is out of proportion to the sign. And recurrent erosions are seen in patients with corneal dystrophies. So the epithelium is not healthy and it can peel off easily. So see, this eye is not very much angry looking and you can't see any sign in the naked eye. If you see through the slit lamp, you can obviously see the defect. But in the naked eye, very hard to see. And if you stain with fluorescein, you can see the defect, like here. This green take-up is due to the area where there is the epithelial defect. Right. So what we do is you put some antibiotic ointment, and then if it is very painful, you can ask the patient to patch the eye for 24 hours. It's not essentially needed, but if it is very painful, you can patch the eye. Antibiotic ointment 3 times a day for 2 weeks, and then you can review the patient in 2 weeks and see. But if you're not confident about what's going on, send the patient to the ophthalmology department. Yes, okay. Any questions? A lot of slides, so I have to do it. I had to go through quickly. Any questions, guys?
We have a few questions posed by the audience. The first one is, could you please explain how early cataracts are treated with spectacles?
Yes, so early cataracts, patients comes with blurred vision, and so the optician can do some adjustments, or the ophthalmologist who seeing the patient can do the adjustments of their lens powers, and then improve the vision to a certain degree. But after a certain level of cataract, you can't do that. So early cataracts, we can manage with glasses by adjusting the lens power. Okay, clear?
Yes, sir. Thank you. The second question is, do we need to suspect retinal detachment in any person presenting with flashes and floaters?
Yes, you have to suspect. Any person presenting with flashes and floaters, unless proven otherwise, you have to check for a retinal tear or retinal detachment. So retinal tear is the most common without retinal detachment. So only a hole or a disruption in the retina. And retinal tear is precursor to the retinal detachment. So if you find a retinal tear, it's very good because you can laser around the tear and prevent a retinal detachment. So anyone coming with flashes and floaters, dilate and see the fundus. If you can't see, still better to send to the ophthalmology departments because they can have a look from their special lenses.
Thank you, sir. The last question is, could you please define high myopia in the context of a retinal detachment?
Yes, so high myopia is when your lens power, spectacle power is more than -6, it's called high myopia. -2 to -6 is usually moderate. Below -2 is mild. So people with high myopia, their eyeball is big, but retina is not big enough and it is stretched to fit into the big eyeball. So stretched retina in a big eyeball is under pressure and there's a high risk that they can get a retinal tear than the normal population. So their retina is thin and stretched and high risk of a retinal tear. That's why they have high risk of retinal detachment.
Thank you, sir. We do have one last question. Is
Okay.
there a type of cataract called brown cataract? And
Yes.
if so, what is it?
Yeah, so those cataracts can be mild, moderate, and severe. So early cataracts, so cataracts categorize into nuclear sclerosis 1, 2, 3, 4, and 5. Brown cataracts are the nuclear sclerosis 5. So in brown cataracts, the cataract color is brown. And you can't see the back of the eyes because of the density. And it is actually a lay term to describe cataract as brown, because it's the usual term is the nuclear sclerosis grade 5, where the color of the cataract is brown, and sometimes it can be even black, and they are very hard, like a small stone, and it's very difficult to do to break them and emulsify them with the phaco machine. It's a very complicated cataract, and it takes a lot of time to do the operation. And what happens in our setting is people do one eye cataract surgery and wait for the other eye for 10 years, and then they get very hard brown cataracts. So the yellow and green cataracts, they are very early cataracts. And then you get white cataracts, and then brown and black cataracts. It's like a lay term to describe cataracts, but we usually use the NS, nuclear sclerosis grading, 1, 2, 3, 4, 5.
Thank you very much, sir. So if there are no further questions, we can wrap up the session for this evening. Again, thank you very much, sir, for participating in this event. And the audience, I would please like to remind you to fill the form so that we can issue your participation certificates. And have a good night. Thank you.